imagine taking heavy daily doses of steroids for a disease you don't even have.
Yeah, which sounds crazy, but for nearly 30% of people currently diagnosed with asthma, that isn't some, medical hypothetical. It's just their everyday reality.
It's wild. And if you are one of the hundreds of millions of people worldwide carrying an inhaler right now, there is a shocking chance the medical community has fundamentally misunderstood what is actually happening inside your lungs.
Right. Because the clinical reality is that what we casually call asthma is not a single, cleanly defined disease at all.
No, not even close.
It's an umbrella term. It covers this chaotic mix of environmental triggers, structural plumbing defects, and honestly, wildly rebellious biology.
Welcome to the Deep Dive. Our mission today is to totally decode this socioeconomic giant of a condition. And to do that, we are pulling from a massive stack of research.
I've got excerpts from a really comprehensive clinical text called Difficult to Treat Asthma, Clinical Essentials. Alongside this truly eye-opening paper from the journal Respirology titled Severe Asthma in Children.
And these sources are, frankly, going to challenge every bit of conventional wisdom you might have about respiratory health.
Absolutely. We're going to explore why the diagnosis fails so often, how everyday environments literally rewire the immune system, and why pediatric asthma completely shatters all the rules of adult medicine.
Okay, let's unpack this, because we really need to understand the sheer scale of the problem before we dive into the biology. Asthma is an absolute behemoth.
It really is.
Like, the data from our sources notes that in 2013 alone, it cost the U.S. healthcare system $82 billion.
Wow.
And if you look at the impact on children, it's heartbreaking. 36,000 kids miss school every single day because of it.
And globally, as of 2015, we're looking at 358 million cases.
Just massive number. So how do we even begin to understand a number that huge?
Well, to understand it, we have to look at the origins of the disease. The data reveals a very complex web of environmental triggers.
Right. It's not just a simple inheritance thing.
Exactly. You don't just inherit an asthma gene and automatically develop the condition.
Yeah.
It requires a highly specific gene-by-environment interaction.
I like to think of it like a complex audio mixing board.
Oh, that's a good way to look at it.
Right. Like, you have your genetic baseline, sure, but then there are dozens of environmental sliders, different exposures you encounter throughout your life.
Yeah, and those sliders all have to line up in a very specific configuration to trigger the disease.
So what are these sliders actually doing?
Well, if we connect this to the bigger picture, those early environmental sliders are quite literally dictating the physical and immunological development of your lungs.
It's fascinating, and the statistical variations we see because of this are just mind-blowing.
Like the Hispanic paradox.
Yes, explain that one, because it really threw me.
So our sources show that asthma prevalence is 15.6% among Puerto Ricans living in the U.S.
Which is pretty high.
It is. But then if you look at Mexican Americans, it's only 5.4%.
See, that feels so counterintuitive if we just, rely on broad demographic labels.
Right. But if we view it through the lens of your mixing board analogy, it starts to make sense.
Because the sliders are different.
Exactly. Researchers believe this disparity comes down to specific genetic admixture, interacting with really distinct geographical environments and migration histories.
So a broad label like Hispanic just completely fails to capture the granular, hyperlocal reality of the disease.
Yeah, it's too blunt of an instrument. The environment plays profound tricks on lung development.
And the farm effect is probably the best illustration of this, right?
Oh, absolutely. So studies compared Amish children with Hutterite children.
Okay, so both groups share very similar genetic backgrounds.
Right, and they both have rural agrarian lifestyles. Yet, the Amish children have significantly lower rates of asthma.
And why is that?
It comes down to farming practices. The Amish use traditional methods that expose their infants to really high levels of endotoxins inside their homes.
Okay, let's break down what an endotoxin actually is, just for anyone listening who isn't a microbiologist.
Good call.
These are essentially fragments of bacterial cell walls, right? Found in things like manure and farm dust.
Exactly. And when an infant breathes in those endotoxins, it acts as an intense early boot camp for their innate immune system.
Like it's training them.
Yes. It teaches the immune cells not to overreact to harmless environmental particles. That early exposure effectively shields them from developing the hypersensitivity that leads to asthma.
But if you take a child with the exact same genetics and put them in an inner city apartment, the mixing board sliders completely change.
They do. And the triggers are not what you'd think.
Right. You might assume the biggest asthma triggers for you in the city would be outdoor smog or maybe cockroaches or stray cats.
But the respirology paper points out a highly surprising allergen.
Which is?
Mice. Exposure to mouse allergen is actually a stronger predictor of severe asthma in inner cities than cockroaches or furred pets.
Wow. Which really demonstrates how hyperlocal indoor concentrations can outweigh broader outdoor factors.
Completely. And we are constantly introducing entirely new sliders to the board.
Like e-cigarettes.
Yeah. The sources note that chronic use of e-cigarettes alters the bronchial epithelial proteome.
Meaning it changes the complete set of proteins produced by the cells lining your airway.
Right. It literally rewrites the chemical building blocks of your lungs.
That's terrifying.
The implications are huge, especially during fetal development.
Yeah, the sources mention pregnancy.
Using e-cigarettes during pregnancy carries the exact same risk for the baby developing asthma as smoking conventional cigarettes.
Because the chemicals cross the placenta?
Yes, and they fundamentally alter how the fetal lung tissue develops its immune memory and its structural architecture.
Okay, wait. I am struggling with this a bit.
What part?
If I think about my own understanding of asthma, I've always been told it is strictly an inflammatory disease.
Right, that's the common perception.
Like, my immune system gets angry at pollen or dust, swells up, and restricts my airflow. Are the sources actually suggesting the physical pipes in my lungs could be built wrong before my immune system even gets involved?
Yes. The old model of angry immune system restricts airflow is pretty outdated at this point.
Really?
What's fascinating here is how the physical plumbing of the lungs and the immune system are in a constant bidirectional feedback loop.
Okay, bidirectional, meaning they affect each other.
Exactly. Sometimes the structural defects exist first, occurring completely independently of the inflammation.
So the hardware itself is modified from the start.
Yeah. Let's look at the inflammation side first, just to set the baseline.
Okay.
Traditionally, clinicians look for type 2 inflammation. This is driven by specific chemical messengers in the body called interleukins.
Right, specifically IL-4, IL-5, and IL-13.
Exactly. Think of interleukins as targeted molecular alarm bells that tell your immune cells to flood an area and cause swelling.
Which is your classic allergic response.
But here's the catch. Many severe asthmatics don't have this type 2 signature at all.
Wait, really? No allergic signature at all?
Right. Meanwhile, their physical lung structure is also going completely off script. The clinical text mentions a phenomenon called dysynapsis.
Dysynapsis, that's a huge word. What exactly is that?
It's a brilliant example of a purely structural defect. Imagine you have a pair of lungs that grew to a perfectly normal or even large size.
Okay, so big lungs.
Yeah, they have a massive capacity for air. But the airways, the pipes leading down into those lung sacs, didn't grow proportionally. They stayed relatively narrow.
Like having a giant balloon attached to a standard tiny plastic nozzle.
That is the perfect analogy. When a clinician measures the breathing of someone with dysynapsis, their forced vital capacity, which is the total volume of air they can hold and blow out, is completely normal or even high.
Because the balloon is big.
Exactly. But their forced expiratory volume in 1 second, basically how fast that air can travel through the pipes, is just average or even poor.
Because of the tiny nozzle.
Right. The ratio is totally disjointed. So even without any immune inflammation whatsoever, this person is at a permanent physical disadvantage.
So the moment they exercise or if they experience even a mild irritant, that disproportionate nozzle becomes a massive bottleneck.
Yes, and it gets worse. The sources also detail how the smooth muscle wrapping around those airways can be intrinsically hypercontractile.
Meaning the muscle itself is biologically primed to squeeze harder and faster than a normal airway.
Exactly. Totally independent of what the immune system is doing.
Wow.
Add to that the issue of tenacious mucus plugs.
Ugh, sounds awful.
It is. We aren't talking about a simple runny nose here. We are talking about thick, rubbery blockages that literally fill the large airways.
The sources said these plugs are a primary cause of respiratory failure and sudden severe asthma attacks, right?
Yeah, they act like concrete blockades in the pipes.
Okay, so if the disease can be driven by molecular alarm bells or disproportionate lung nozzles or hyperreactive muscles or rubbery mucus, it is no wonder doctors struggle to define it.
It's a diagnostic nightmare.
Which brings us back to that startling statistic from the very beginning. If the presentation is this structurally confusing, how does the medical community address the 30% of diagnosed patients who don't actually have the disease?
Well, the clinical texts refer to a cultural shift in medicine that has driven this massive failure rate.
Like a shift in how doctors prescribe.
Yeah, there has been a massive backlash against objective lung function testing. Inhalers have almost become, in the author's words, a fashion accessory.
A fashion accessory. That's a brutal way to put it.
But it's true. A doctor might observe a patient out of breath, write down possible asthma as a safeguard, and just hand them an inhaler.
But without objective testing, that casual possible asthma label becomes permanent just by sheer force of repetition in the patient's medical chart.
Exactly. We end up with millions of people walking around treating the wrong disease, falling victim to what the sources call the asthma plus problem.
Or asthma mimics.
Right. And these mimics are incredibly convincing if you don't look closely at the mechanics.
Give me an example.
Take a condition called ILO. That stands for exercise-induced laryngeal obstruction.
Okay, ILO. If you've ever watched a teenager gasping for air on a soccer field, your first instinct is probably to grab an inhaler, right?
Sure, because ILO looks exactly like a severe asthma attack. But the mechanics are entirely different.
Because in asthma, the lower airways constrict after or during prolonged exercise, making it incredibly difficult to breathe the air out.
Right, the lower pipes. But in ILO, the larynx, the vocal cords at the top of the throat, inappropriately closes during peak exercise.
So the patient is struggling to pull air in.
Yes. The clinical text notes they exhibit inspiratory stridor, which is this distinct high-pitched gasping sound on the inhale.
And because the bottleneck is happening in the throat, handing that teenager a beta agonist inhaler, like albuterol, is completely useless.
Utterly useless. The medication goes to the lower lungs, while the vocal cords remain locked shut.
What they actually need is a specialized speech therapist or physiotherapist to teach them mechanical control of their larynx.
Imagine giving a developing child heavy systemic steroids for years when they just needed targeted vocal exercises.
The diagnostic failure causes real, actual harm.
It does, and obesity is another massive mimic highlighted in the text.
Because the physical weight on the chest wall mechanically alters how a person breathes.
Exactly. It reduces compliance,
Yeah.
meaning the lungs struggle to expand against the literal weight on the chest.
This leads to something called atelectasis, right? Which is essentially collapsed lung tissue at the base of the lungs.
Yeah, the sheer weight squishes the tiny air sacs shut.
But how does that mimic asthma on a test?
Well, if that obese patient takes a really deep breath or uses a bronchodilator inhaler which forces them to take a deep breath, those collapsed areas physically pop back open.
So on a basic, non-rigorous lung function test, that sudden improvement in airflow mimics the reversible obstruction doctors expect to see in asthma.
You nailed it. The patient gets an asthma diagnosis for a problem caused entirely by chest wall weight.
Unbelievable. And the physical pressure of obesity also naturally leads to looking at other comorbidities that trick the lungs, like stomach acid creeping into the esophagus.
Yes, gastroesophageal reflux, or GOR.
A huge percentage of children labeled with severe asthma have acid reflux.
They do.
Yeah.
But the source is incredibly definitive here.
Yeah.
Treating the acid reflux does absolutely nothing to improve asthma control.
Nothing.
Nothing. The acid doesn't cause the airway constriction. It is an associative symptom, not a causal mechanism.
Wow.
The respirology paper insists that fixing the diagnosis and stripping away these physical mimics is the absolute first step. You cannot label someone as having severe asthma until you prove the asthma is actually there.
Which brings us to a crucial crossroads in the clinical text.
Right.
Let's say a clinician rules out the vocal cord spasms, the collapsed lung tissue from obesity, and the acid reflux. They prove the child definitively has asthma. But the child is still suffering despite taking high doses of medication. We have to draw a very thick line between difficult asthma and severe therapy-resistant asthma, or STRA.
Yes, because that distinction dictates the entire treatment path.
So, difficult asthma.
Difficult asthma means the biological disease itself might be easily manageable, but the patient's environment or behavior is making it difficult.
Okay. And severe therapy-resistant asthma.
That means the actual biology of the disease is fundamentally ignoring the drugs.
Okay, so is diagnosing severe therapy-resistant asthma without checking if the kid is actually taking their daily medication basically like blaming your car engine for being broken when you just forgot to put gas in the tank?
That's exactly what it's like. You cannot evaluate the engine if the fuel never reaches it. Adherence to medication is a massive hurdle in difficult asthma.
Right. Patients, particularly teenagers, frequently just do not take their daily preventative inhalers.
No, they don't. And to combat this, doctors are using electronic monitoring with audio signals.
Audio signals, like they record the sound.
Yes. It isn't enough to just count how many times the inhaler cartridge was pressed. The audio signal tracks the acoustic signature of the breath.
To prove if the child actually inhaled the medicine into their lungs.
Exactly. Or if they just sprayed it into the bedroom air to trick their parents.
That sounds like espionage.
It might sound like espionage, but the stakes require it. Think about it. If a doctor escalates a child to heavy systemic steroids, which carry terrible side effects like stunted growth and bone density loss, when the child simply wasn't taking their basic preventative inhaler,
then the medical system is doing active harm.
Absolutely. The sources also delve into the sensitive territory of safeguarding.
Yeah, this was a heavy section.
Sometimes the symptoms were entirely exaggerated by the family or the child due to deep psychosocial stress.
The respirology text points out that teachers on the sports field are, quote, shrewd observers. Because if a child's family reports terrifying, life-threatening asthma attacks every night at home, but that same child runs around the track at school in the freezing cold with zero symptoms, the clinical story is flawed.
It requires clinicians to become detectives. They literally have to rule out behavioral non-adherence, poor inhaler technique, continued exposure to a hidden allergen, and psychological factors.
So what happens when they do all that? If a doctor controls for all of that, brings the child into the hospital, administers the medication directly under observation, and the lung function still fails to improve.
That is when you enter dangerous territory.
Because to definitively prove the child has true severe therapy-resistant asthma, the doctors deploy the ultimate test.
Right. A single intramuscular injection of triamcinolone, which is a highly potent steroid.
Because bypassing the inhaler entirely removes human behavior from the equation.
You cannot fake an injection. The steroid goes directly into the muscle and systemic circulation.
So what's the actual protocol?
They give the shot, wait 4 weeks, and measure lung function. If the child's breathing drastically improves, it proves the biology of their asthma was always steroid responsive.
Meaning the reason they were sick at home was simply non-adherence?
Exactly.
So what does this all mean? If you give that injection and 4 weeks later the child's lungs are still heavily obstructed, you have isolated true severe therapy-resistant asthma.
Yes. The biology of their disease completely ignores the most powerful anti-inflammatory drugs modern medicine possesses.
And isolating that specific group of children leads us to the most profound revelation in the research.
It really does. When scientists look at the biology of pediatric STRA, they discover that almost everything we know from treating adult severe asthma is utterly wrong.
Wait, so I want to frame this clearly for anyone listening who uses adult biological drugs. If asthma is an umbrella, are kids just standing under a smaller version of the adult umbrella, or are they existing under a totally different canopy?
Oh, they are under a completely different biological canopy. Treating pediatric severe asthma as a miniaturized version of adult asthma has been a massive clinical failure.
Wow. Why?
Well, in adults, severe asthma is heavily driven by those Th2 interleukins we mentioned earlier.
The alarm bells.
Right, alongside a specific type of white blood cell called an eosinophil. Knowing this, pharmaceutical companies developed incredible monoclonal antibodies. These are targeted biological drugs that hunt down and neutralize those specific Th2 pathways.
But when researchers performed invasive bronchoscopies to look directly inside the lungs of children with severe therapy-resistant asthma, the twist is that they found these kids often lack Th2 cytokines entirely.
The molecular targets simply aren't there.
So the adult drugs are hunting a ghost.
Exactly. Instead, the inflammation in these children seems to be driven by an entirely different, much more primitive part of the immune cascade.
What part?
It is driven by innate epithelial cytokines, specifically one called IL-33, and cells known as lineage-negative innate lymphoid cells, or ILCs.
Okay, let's ground that. What is an ILC compared to a normal white blood cell that reacts to an allergy?
Good question. Traditional adaptive immune cells learn to attack specific triggers, like mouse dander or pollen. ILCs are much more primitive.
Like a baseline defense.
Yeah, they sit directly in the tissue lining the airway and act as a generalized alarm system. They don't wait for a specific allergen. They react instantly to generic cellular stress or damage, flooding the area with intense inflammation.
And the biological rebellion gets even stranger when we look at the neutrophil paradox.
Oh, the neutrophils, yes.
Because neutrophils are essentially the body's microscopic SWAT team, right?
Right. They are white blood cells normally deployed to kill bacteria.
And in adult severe asthma, Finding a high presence of neutrophils in the lungs is terrible news. It means the asthma is aggressive, highly steroid resistant, and the chronic collateral damage from these SWAT cells basically ruins the lung tissue.
But the pediatric data shows the exact opposite.
Which is why.
It really is.
Yeah.
Intraepithelial neutrophils in children with S3R are actually associated with better lung function, higher asthma control test scores, and a lower requirement for steroid medications.
The very cells that destroy adult lungs are somehow protecting pediatric lungs.
This raises an important question. Why does this paradox exist?
Do we know?
The working theory is that in these specific children, the neutrophils are actually doing your intended job. They might be successfully fighting off low-grade, hidden bacterial infections that are secretly driving the airway stress.
That makes a lot of sense.
But whatever the specific mechanism turns out to be, it proves definitively that we cannot blindly extrapolate adult disease models down to children.
No. The biology demands a completely personalized approach.
Absolutely.
Asthma is not a clean binary diagnosis you can just point to on an X-ray. It is a massive umbrella.
It is.
It spans quirky environmental sliders, where endotoxins on an Amish farm build robust immune systems while inner-city mice trigger intense inflammation.
And it spans structural plumbing issues, like dysynapsis, where your pipes simply don't match your lung capacity.
Right. It encompasses diagnostic illusions like vocal cord spasms and the mechanical weight of obesity that trick doctors into prescribing heavy, unnecessary steroids.
And it culminates in age-specific biological rebellions, where the cellular mechanisms in children operate in complete defiance of adult therapies.
Personalized medicine isn't just a clinical buzzword anymore. It is the absolute baseline requirement for navigating this disease.
I couldn't agree more.
So for you listening, the next time you hear someone casually mention they have asthma, or you see an inhaler resting on a desk, you'll know to wonder about the hidden mechanics. Is it type 2 inflammation? Is it a dysynapsis bottleneck? Or is it an undiagnosed vocal cord spasm?
The label of asthma is merely the starting line of a deeply complex biological investigation.
Here's where it gets really interesting, though. If factors like the Amish farm endotoxins and specific early microbiomes dictate the physical and immunological growth of the lungs, it completely changes the timeline of medical intervention.
It shifts everything to early prevention.
Exactly. Could the ultimate cure for asthma have nothing to do with better inhalers, stronger steroids, or new biological drugs?
That's a profound thought.
What if the future of preventing this socioeconomic giant involves prescribing controlled environmental exposures to infants to literally grow better lungs before the disease ever has a chance to take root?
Growing better lungs, it's totally possible.
It is definitely something to mull over. Until next time, keep diving deep.